Welcome to Sex Ed with DB. I'm your host, DB. Let's get into it. I'm about to get personal here, so listen up. I'm going to tell you a fun fact about me that you definitely didn't know. The lube that I use most consistently is Uberlube. I really mean it. If you were here with me right now, I'd tell you to go over to my nightstand drawer and tell me what you see. That's right, you would see a bottle of Uberlube. If you've never heard of Uberlube, let me tell you about it. Uberlube is a silky smooth silicone-based lube recommended by leading doctors, and its body-friendly ingredient list makes it widely used by people with sensitivities to lubricants. Another amazing thing about Uberlube is that it doesn't leave a sticky residue like water-based lubes do. It lasts for a long time and doesn't stain clothing or bedding. I have 3 bottles of Uberlube on my bedside table right now, ready when I need it. If you're someone who wants to feel more pleasure in the bedroom, use code SEXEDWITHDB for 15% off at Uberlube.com. Trust me, it's amazing. We talk a lot about sex ed, but when we're shopping for products to support our sexual wellness, exploration, and expression, we head to the experts at Lion's Den. For 50 plus years, Lion's Den has been a leader in adult products. Whether you want to explore a new kink or add a little romance to your evening, Lion's Den has something for all. Each location is brightly lit and staffed with the very best experts in pleasure, passion, and romance, so you can feel comfortable and confident in your purchases. Lion's Den is offering our listeners 15% off your purchase in-store and online using code SEXEDWITHDB at lionsden.com. Magic Wand's story begins in 1968, a full year before we landed on the moon and about 6 months before bell-bottoms were trendy the first time. This is when the Magic Wand, the original personal massager, was first introduced, and I am so glad it was. No one expected that this unassuming device would soon become one of the world's most recognizable products. The Magic Wand Original exemplifies the phrase icon, and now it shares the spotlight with 3 equally impressive models: Magic Wand Plus, a corded variable speed massager, Magic Wand Rechargeable, a cordless multifunction device, and the first ever Magic Wand Mini, a new, compact, adorable, rechargeable massager. Every product that bears the Magic Wand name features the legendary power and historic pleasure that took the world by storm more than half a century ago. My personal favorite Magic Wand is the original. They sell millions every year, and for good reason. It's powerful and brings so much pleasure in all the right places. Want to get a discount on this amazing powerhouse? Go to sexedwithdb.com/magicwand to learn more.
You know sex is supposed to be fun, right?
We landed in Reykjavik and we're like, competition is on. We're all getting laid.
I'm Billy Procida, host of the Man Whore Podcast. I've been doing this show for over 9 years, and I still get surprised by the stories my guests have to share.
And my date was my dad's girlfriend.
Whoa, we gotta really back up. Want to know what all of that was about? Follow the Man Whore Podcast wherever you listen to audio. And stay slutty.
Hello, everybody. I am coming to you as a wedded woman. I recently got married a little over a week ago, and I am still on that wedding high. It was, one of the best days of my life, / the best day of my life. I feel I really judge people when they used to say that. And I would hear it and be like, ugh, is your life sad? That sounds really intense and a lot of pressure. But they're onto something. It was really special. My heart is very full. I feel so lucky to have such an amazing partner and family and friends to celebrate with. And having you all to tell this to makes it that much sweeter. So thanks for your love and your support just of me and Sex Ed with DB over the last 7+ years. You all have really gotten me to this point of my relationship. I started Sex Ed with DB like my first year of dating my now husband. And it's so special to see like how it's grown. And he's been like my biggest cheerleader through it all. So I wanted to share that piece of news with you. And how fitting that today's episode is me interviewing my sweet mom, Dr. Rebecca Levy-Gantt. And she's been on the podcast, like, I don't know, honestly, I haven't counted, but I think like 10 to 15 times, probably like 13, 14, 15. And yeah, if you haven't heard an episode with her, she is so smart. She's brilliant. She's fantastic. She's funny. She's such a good teacher and educator. And I love having her on. She has been an OBGYN practicing for 30 years. And for the past, 10 years has been practicing in her own practice. And she owns her own practice in Napa, California. And she is an amazing mom. And she also is a runner. And she's very good at art, annoyingly. Has great handwriting. She has a lot of talents. But she also is a writer and has authored 3 books. Her most recent book is Perimenopause for Dummies, like the Yellow Dummies books. She is a fucking baller, out of control. We're going to put the links to her books and her website, Premier OBGYN, in the episode description. So definitely check them out. So gynecologically speaking, there have been new things that have been coming out in the news. And one of those things that we talk about in this episode is new technology for pap smears. There is this ability now where folks can do their own pap with a self-collection tool. And so we talk about that, the pros and cons of that. And then we also talk about pain management guideline updates by the CDC for IUD insertion. And my mom explains all about like how is an IUD even inserted and kind of like why these guidelines should have been in place many years ago. And so, yeah, this is a great, great episode. I hope you enjoy it. Here I am with my amazing, lovely, beautiful mom, Dr. Rebecca Levy-Gantt. Good evening, Mom.
Hi.
Hi. How are you doing?
I'm good. How are you?
Just married.
You are? When did that happen?
Mom, you're the first person who I'm talking to post-wedding. Haven't talked about it. Haven't talked about it on the pod yet. Mm-hmm. Yeah, what a crazy thing that David and I did, and it was so fun.
You plan it for a really long time, and then guess what? It actually happens.
Surprise. Yeah, it was really like a year of planning after 8 years of dating.
Well, it was inevitable then, I guess.
Perhaps.
It was lovely, and people had a really good time, and you guys had a really good time. I had a really good time. It was fun.
Yeah, it was so sweet. I loved every minute of it, and it was so cool to. I don't know. You never have everyone you love and know in one place. You don't get that lucky.
Well, you know what they say: weddings and funerals.
Weddings and funerals.
Funeral, you won't be there to know about it.
I know. It made me really feel like I want a living funeral. I feel like those should be more popular, but that's for another time. But yeah, it was just I don't know. I think that I expected it to be so wonderful and kind of scoffed when people were like, it was the best day of my life. But I kind of maybe felt like that. I don't know, like one of the best weekends of my life for sure.
It sure looked like you were having the best day of your life.
Yeah, it was really, really special. And it's just so sweet to like wear wedding rings and like call each other husband and wife. And we're in our wedding, post-wedding bliss still, I would say.
Well, I think you guys had pre-wedding bliss. I think you've had dating bliss. I think that's kind of what led up to this, right? That's
true. That's very true. Well, I'm really glad to have you on the pod today. You're our last guest focused episode of the season, which is very fun. And today we're kind of talking about like GYN topics that are coming up in the news, namely, this alternative to the pap smear, where we're going to kind of talk about where people are going to be able to kind of do self-collection, which could change the game for pap smears. And then we're also talking about new CDC guidance about pain management options for IUD insertion. So chock full of good stuff today. But before we do that, let me introduce you to our new segment called The Quick and Dirty. It is an intro segment we do with all of our guests. Don't be too afraid. She looks afraid. Where we have 3 quick questions that we ask you, and we see what you think of them. So the first one is, what is your biggest current sex ed hot take, if you have it? What's something, if you say it, people are like, oh, interesting. Tell me more. Or that's, I want to hear more about that. What's going on? I guess that's the same thing I just said, but you know what I mean?
Well, there has been something in the news lately, and I know we're going to talk about all news topics on this show today, but there was a small study that was talking about cream Viagra for women that they can use like prior to a sexual event to help with arousal. And like there have been a million things through the years, like different creams and warming gels and all kinds of things. And they've tested Viagra for women before in a pill form and never really came to the conclusion that it was great for women the way it seems to be for men. And then there was this small study that said using Viagra cream for women on, let's say, key areas like around the clitoral area, around the vaginal opening, 20 minutes or something like that before sexual activity somehow enhances arousal. Maybe not exactly in the same way it does for men, because I think with men it's more of a physical thing. And I think women are looking for more of a combination, maybe of physical, but also mental, in order to kind of be more interested or more responsive. But it was out there in the news, and I always can gauge what's in the news by what people come into my office asking about. Mm-hmm. And I've had several people ask about it, and I'm really willing to talk about it and see if that's something that would help women who are kind of complaining of those types of problems.
So is your hot take that we should be paying more attention to it, or what would you say?
I would say that now more so than ever, just like menopause is having a hot moment, women's sexuality is having a hot moment, and people are paying attention and trying to find new ways. And any place there's interest, of course, there are people trying to serve that interest, sometimes monetarily, but sometimes like we want just women to feel better.
Totally. So, yeah. Next question for the quick and dirty. What would you say is one thing that you wish everyone learned in sex ed growing up?
Oh boy. I think I can come back to things that I say when I see a young person in my office. Like, my practice is mostly menopause. I see mostly people over 45, et cetera. But every once in a while, I see a very young teenager, like who's kind of just starting. We call it, haven't maybe not yet had their sexual debut, we call it. And especially now, since it's August, a lot of people are going to be going away to college. So we see a lot of people. I make sure to have this very particular conversation, like sit down in the office with them, like before I decide whether they need an exam or they need testing or what they want to talk about. And I have a particular conversation with them about several things, like when or if you're going to be sexually active. 1, consent. 2, pleasure. And 3, you want to be sure that it is not just for the other person, because if it's not making you feel good and you're not enjoying it, you really shouldn't be doing it.
Amen.
So I really feel like that's important for me to say to them as not their mother and not someone who's just wagging a finger at them, but saying, hey, I have a job because people have sex. I want people to have sex. But you can have such a big influence on people who are kind of just starting out to see where they get their ideas from. And, these are high school girls mostly. So you have to kind of figure they do need my guidance or my attention or my explanation, or for me to be able to answer some questions for them. But for sure to tell them that it's not about someone else, which, as well as I do, that's kind of the pervasive thing when you're young, thinking, how will he like me? What should I do for him, or whatever partner you have? But I feel like the need to, if we're also talking about birth control, we're also talking consent and pleasure.
Yeah. I feel like that's kind of the perfect opportunity, because most of these people aren't getting it in school. So like at the gyno before college should be getting it earlier for sure. But if you could kind of use that inflection point to educate, that's a really big opportunity.
Yeah, it is a very typical visit. Like sometimes a mom will make the appointment, but then the mom doesn't come in with them because they really would rather talk to me themselves. And I feel like it's so information packed, that, and I, we leave it open. We have like a patient portal. They can write me, they can ask me a question, everything. And I feel like they leave with good information. So I wish that was a very typical thing available to everybody.
Commonplace for sure. And the last question we have is, what is your favorite thing about being an OBGYN and least favorite thing about being an OBGYN?
My favorite thing about being an OBGYN is I have always felt that I want to empower women with the knowledge of their own bodies and their physiology and the science of what is truly accurate information. And I feel like I do that every minute of every day. And as much as I would say maybe on the other side, what is frustrating about it, what do I not like? I don't like, and of course I'm dating myself, but I don't like that ever since this internet came out.
That dang internet.
Yeah, that darn internet. It's so annoying because there is so much information and false information out there that I feel like I have to spend at least half of the time when I'm having a conversation with somebody dispelling information first, setting them straight about what they're reading or hearing or thinking about or planning is not probably either not safe or not evidence-based or not science or not real. I spend a lot of time doing that. And like I said, I like the part where I'm educating and talking to people and empowering them, but I'm not starting from ground zero anymore. I'm starting from below that because people come in with all kinds of ideas and not so much come in and go, I wanted to know if this was right. They come in with the idea and the plans, and they're already doing the things. And they kind of want me to go along with it, or they want to just tell me what they're doing and this is fine and not
You want your like stamp of approval.
Yeah. And that's probably at this point what I like the least. If you asked me a couple of years ago, the thing I like the least would probably be I really never got enough sleep.
Oh, that's real.
You know, delivering babies and being on call and always trying to be available. This kind of job, it's not a shut off kind of job. It's not a job where you can go, oh, I'm sorry to dermatologists, but I don't think you have any dermatology emergencies in the middle of the night. I have a bad pimple. You know, I get why people go into that. I don't think they do it for the love of skin mostly. I think they do it a lot. It's interesting and the lifestyle, you know. So, but since I don't deliver babies anymore, I don't have any or many menopause emergencies. I have a bad hot flash.
Right. You know, could feel like an emergency.
Call me back right now. Well, you know, you'd be amazed at what people think is an emergency, but I feel like that time for me is over. So
totally. And thank the Lord, because you need a good night's rest. Okay, so we're going to transition now into talking about pap smears. So our kind of conversation about this is a little bit based off of a recent New York Times article called "An Alternative to the Pap Smear is Here, No Speculum Required." And so the gist of it is that this fall, self-collection kits for cervical cancer screening will become available in doctors' offices. And so I'm curious if you can kind of talk us through, like, what are your thoughts on this article, thoughts on these kits? What do our listeners need to know about them? And how do you think they might impact overall cervical cancer screening rates?
Okay, well, first let's talk a little bit about the pap smear itself, because I do think there are a lot of there's a lot of false information or misunderstandings, I would say, about doing a pap smear. And guidelines for pap smears and doing pap smears have really changed over the years. Like years ago, we used to do one type of pap smear, and then it switched to doing a pap smear with HPV testing. And now, pretty much, if you look at the CDC guidelines, they recommend, or if you look actually at the American Cancer Society guidelines, they recommend screening for anyone who has a cervix from age 25 to about age 65. And it's not like it used to be where every year someone would come in for their annual exam and every year they'd get a pap smear. And then a pap smear is a screening test for cervical cancer. So the cervix is the opening or the mouth of the womb or the uterus. So if cervical cancer is going to be present, it is usually present in the opening to the cervix. So we call it the cervical os or the opening. So in order to do the screening, we would take a brush and brush some cells from the cervix. And we would either look at it on a glass slide, or we would put it in some liquid, formalin, and send it to the lab. And they were always looking for abnormal cells. So that's called cytology, looking for cells that are abnormal on the cervix, which could be either precancerous or something called dysplasia, which are precancer, or cancer. But then it came to be that we realized that what is causing all those abnormal cells to be on the cervix? And it turns out that a sexually transmitted virus, HPV, human papillomavirus, which is the most common sexually transmitted virus, is the cause of not all, but almost all changes on the cervix that would lead to dysplasia, precancer, and cancer. So the guidelines have moved in the direction of, hey, why don't we screen for HPV? Because if someone doesn't have HPV, whatever else they have in terms of inflammation or abnormalities on the cervix, it's likely not dangerous enough to be worrisome for cancer. And then they said, and you don't really have to do that every year because the cells change very slowly. So if somebody has HPV and you then look at those cells again in a shorter interval of time, you'll hopefully catch something before it changes from just being present to making dysplasia, to making precancerous cells, and then cancer. Because if you're screening someone into a yes, there's something there, or no, there's not. So if you screen for HPV and it's not there, the guidelines now say you don't have to again screen for several years. And depending on who
3 years, right?
Sometimes it's 3, but some other guidelines actually say 5. However, people have to understand that even if you look at guidelines, you still have to individualize it, because there are people that are going to be at higher risk and lower risk. Now, when an older woman, let's say 60 years old, who's been married or monogamous for many years and never had an abnormal pap and never was diagnosed with HPV, you're a little hard pressed to say this person needs to be screened every year if there's no new partner in the picture, because the new partner is the source of the HPV that will then change the cells on the cervix to possibly have cancer. And in this country, I would say statistics show that almost everyone who ends up with cervical cancer, not everyone, but almost everyone, is either from a lack of screening before it turned into a cancer or other risk factors that they have. So if people go to their screening, and that's why this home collection or patient-centered collection is important, because there are many reasons why people do not go to offices where screening, HPV testing, pap smear testing is available. So this new test was FDA approved, I believe it was May 15th, for self-collection. And, we'll talk a little bit about what self-collection means. Now, I absolutely have seen people in my office that, for whatever reason it was, either are uncomfortable or cannot, or have too much pain, or are anxious, or any reason that they just cannot get into a position which is, uncomfortable, very invasive. And that would keep them from getting screened. So I'm all for whatever test makes more availability to a patient to be able to do if they can't do the typical screening test. So I've absolutely had patients in my office where they had a complaint, discharge, or some reason that I would have to do a test like a culture or something. It would be a good idea to get a culture from the vagina or from the cervix. And I realized they are not planning to get up into the position for me to do it. And I would go, here is the culture. I would show them how to do it. I would leave the room. They would swab, and I would send it to the lab, and we'd get an answer. So that's the whole idea behind these new tests. Now, at this moment, when they're first going to become available, which is very soon, they will be only to do it in what they call a health care facility. So that includes doctors' offices, clinics, pharmacies is even on the list. Believe it or not, I can't imagine going into a pharmacy and doing your self swab, but they may have areas set up for that. So is it as good as looking at someone's cervix and doing a survey and seeing what else might be going on? I don't think so, because there's value in an exam. I certainly have examined somebody who had no complaints and found something that I only found by examining them. So
separate from the cervical screen.
Either I saw something on the cervix, like, if I examine somebody who, let's say, by guidelines doesn't have pap smears anymore, a woman who's like 70 comes to my office for an exam, and I have definitely found cases of cervical cancer by just looking at someone's cervix. Not that I could always look at it and say that's cancer, but I could look at it and say that's not normal and do a swab and find cancer or precancer cells. That's rare, but you lose that ability to do your visualization if everyone, let's say, suddenly were self-swabbing and you never got to look at anybody. The benefit in the self-swab is for people who otherwise wouldn't have been screened, because that's a whole parade of people that you're taking out of the I didn't screen category and now screening. So the way you self-screen, it's a swab that kind of looks like a Q-tip, almost like swabbing for COVID. When you put it in your nose, you actually put it into the vagina and you rotate it around a certain number of times. You may or may not be touching the cervix, but that's not the point. It's a vaginal swab. So, and it's strictly testing for HPV. It's not testing for abnormal cells. It's an HPV test. So then, of course, there's going to be an algorithm, because if they're testing because there's no way anyone can ever look at their cervix because of whatever reason, what are you going to do next? Because if they swab and HPV is positive, and don't forget, I know you know this, but HPV is not all the same. There are different strains. So if you come up with a positive that's an HPV strain, which would be like 16, 18, a couple of other ones that are the more aggressive ones and more likely to cause a cervical cancer, now what are you going to do? Are you going
What's the next step?
Yeah. So there has to be an algorithm after that and discussion, of course. You don't just have someone walk in, hand them a swab and this is great, let's just swab and it's as good as anything else. No, it's better than not swabbing. But for people who don't have this available to them or who cannot do it for some reason, absolutely, it's a boon, it's a benefit.
This was going to be my next question, which is like thinking of people who have these barriers, right? Like you touched on this. There are people who have experienced trauma, who are sexual assault survivors, who for one reason or another are not comfortable and feel like they're not able to do this. And then on the other end, that we know that cervical cancer disproportionately affects certain groups, right? So like Black and Latina women and those who are in rural areas. And so thinking through, okay, how are we helping those folks reach step one in order to get that then step two, which is then hopefully seen by a gynecologist in person, to then do a pap smear, then figure out, okay, does this HPV mean that this person also does have cervical cancer? If they do, what does that look like? Do they have precancer cells? Like what I guess is say that person gets that self collection swab and they have HPV, right? Like what is the next best step in order for them to do what they need to do?
The way it's on the guidelines right now about the screening is if they come up with HPV positive, if they screen positive, then they must talk to their doctor about what the next step is.
Okay.
Because then the doctor or the healthcare professional is going to have to talk to them about, is it just another swab in 6 months or something like that? Or is it this HPV along with your other risk factors? Because, this is supposed to be for screening in people who are general risk. You shouldn't be taking people who are very high risk to have cervical cancer and just saying a swab is as good as me looking at your cervix. A swab is better than no exam, but you really have to kind of have that discussion with people that if you have somebody who's very high risk, that you need to look at their cervix. There are other ways to look at people's cervixes. If people can't tolerate it in the office, there are sedation, there are exams that are done under anesthesia. Absolutely. I've done them. But people really have to understand that when you're offering this option, you have to offer it to somebody who's likely to benefit from this over no screening. And like you said, certain groups, why is there a higher incidence of cervical cancer in certain populations, lower socioeconomic or Black communities? Part of it is because of lack of access to care, right? I mean, almost nobody has frank cervical cancer if they've had regular screenings. Almost nobody. I saw someone with cervical cancer in my office several years ago, and in my practice, I don't see it often. I see a lot of HPV. I do a lot of biopsies. I do a lot of, algorithms where people need more testing and things like that. But the one person in the last 8 years who came in with a frank case of cervical cancer was like 50 and hadn't been to the doctor since she had a baby. And that's very common, that someone, when they finish their prenatal care, once they deliver, they don't go back to their OBGYN. They just don't want to subject themselves to it. They don't have time. They're busy. Lack of access or lack of going is a big reason that people end up in a farther along category of, dysplasia or cancer.
Yeah, and we've talked about this with you on the show before, but just the fact that HPV, right? Like you can get, the Gardasil, is it still called Gardasil?
Gardasil, right. Well, that's the one that Merck makes, yeah.
Yeah, well, that's the name of the multiple shots that you get in order to prevent some strains of HPV, but not everyone has access to that. Not everyone knows about it, and it doesn't prevent against all of them. And like you said, HPV is the most common STI in the US, and more often than not, you don't have symptoms, or if you do have symptoms, maybe you get them and then it goes away on its own. I feel like there's still a lot that the medical community doesn't really know about HPV.
Also, there's a small percentage of cervical cancers that are not HPV caused. So what about if somebody has something called adenocarcinoma, which is carcinoma or cancer in the glands of the cervix, not usually HPV related, and you only know that by actually doing a pap smear where you put the brush into that cervical opening. So those will be missed if this becomes standard of care.
What percentage would you say of people have that kind of cancer?
Funny you asked that. Well, the percentage of adenocarcinoma, which is HPV negative, is between 15 and 40%.
That's a lot.
Yeah, it's a glandular carcinoma, and most people have never even heard of it. And I think I found my first glandular, it wasn't carcinoma, but it was carcinoma in situ, which is like one step right below that. And someone who came to me for preconception counseling, came to me because she's thinking of getting pregnant. And I said, okay, let's do all your up-to-date testing and all that before. And that pap smear came out with one of these very close to cancer cases. And had I not put that brush in that opening, would not have diagnosed it. And now she's treated and now she's actually pregnant. So, it's just, when you look at a new technology, you have to look at a couple of different visions for that technology. Will it serve people who right now are not being served? Absolutely. Is it for everybody? Can women just go, oh, so great, I never have to go to my doctor's office anymore or ever get a pap smear again. I can always just swab myself. No, you know what the important part of this is? The education. The education on, first of all, what is a pap smear? Why are we doing HPV testing instead of the old cytologies that we used to do? Who is not up to date on this or not following guidelines? And honestly, the general population doesn't know, because let's say when I see a new patient and I go, oh, when was the last time you had a pap smear? Oh, I had one, last year with my other doctor or something like that. And we go back and look at records. They didn't have a pap smear. They think every time they have a pelvic exam or somebody does any kind of, observation of that area or does a swab for infection or something like that, that's not a pap smear. And we hear that all the time.
Totally. I feel like there must be some sort of app, or there should be, where you can track all of your appointments. Like the last time that you checked your breasts, the last time that you got a pap smear, the last time that you checked your moles, like whatever that you need. Because I am someone who is annoyingly organized, and I still don't remember myself on like when all my stuff is.
Well, you're that checklist person.
Yes, exactly.
Check the boxes, man. Do all your stuff. I mean,
yeah, exactly. But moral of the story here is that new technology is good. We just need to continue to educate people around like the ways in which to use it and make sure it doesn't replace a visit to your doctor's office.
100%. Yeah. And if you're looking at certain populations, immunocompromised, people who have had abnormal PAPs in the past, they're not in the same category of people who can just do a swab and avoid, an exam or something like that. Everything has to be individualized. So that's why there should be no exams or any swabbing or any tests done without that adjacent counseling and education so that people know what they're doing a test for and why. And I have to say, I love to explain things to my patients, but even with the time that I have and the ability that I have to like give people handouts and talk to them for a long period of time, they still kind of don't remember exactly what we were talking about. And, it's critical that people are able to take care of their own health care by knowing, because nobody's going to follow them around.
Do you want to learn about common sexuality topics, including STIs, jealousy, pleasure, non-monogamy, sex work, how to be a better client? Hi, I'm Elle Stanger. I'm a certified sex educator, and I'm an adult entertainer and porn maker. And I host weekly episodes to talk about some really common and some very unknown things about sex and sexuality. Find They Talk Sex podcast on Spotify, Apple Podcasts, or theytalksex.com.
Ever since getting engaged to my wonderful fiance, I've been thinking about ways to keep things fun and novel between us. But I, of course, want it to feel organic. I want to be able to feel sexy and comfortable in my body while trying something new. Thanks to Lion's Den, a new adventure I've been exploring is the world of lingerie. I never really was a big lingerie girl myself, but once I started trying on lingerie that accentuated my curves, felt super soft to the touch, and made me look in the mirror and felt wildly confident in my skin, that changed pretty quickly. Plus, when I searched for what I might like on Lion's Den's website, I saw models that actually looked like me. They were curvy and thick and voluptuous, and it made all the difference to see models that have my body type. Want to join me in my new lingerie chapter? Right now, you can use code SEXED with DB for 15% off your purchase in-store and online at lionsden.com. Follow them on social media at Lions Den Adult on IG and TikTok for exclusive offers, deals, and giveaways. Let's talk about a lube I absolutely love, Uberlube. Uberlube makes sex better for everyone by reducing friction and increasing pleasure. Whether you're using it for solo sex, sex with a partner, or both, Uberlube has a long-lasting performance that lets skin feel skin. It has simple, body, and condom-friendly ingredients, is scent and color-free, dissipates when no longer needed so there's no sticky residue, and is recommended by leading doctors. Use code SEXEDWithDB for 15% off at uberlube.com.
Hey everyone, Amy from the Shameless Sex podcast here with a special invitation for couples of all orientations and genders. Are you wanting to amp up your intimate connection with your partner? Maybe you want to add more spark and sexy aliveness into your relationship. Or perhaps the two of you just need to get away from it all and just be in paradise with yours truly in beautiful Costa Rica. Then you need to come to our Shameless Sex Couples Retreat. This luxury retreat is 5 days and nights of workshops, relaxation, adventure, fun, and play, plus beachfront and surrounded by toucans, monkeys, sloths, and all the creatures of the magical Costa Rican jungle. And it's all inclusive, so you don't need to worry about a thing once you get there. So if you want to pamper your lovership, then please join us November 12th through 17th, 2024. Spaces are limited to 6 couples, so snag your spot ASAP. To learn more or to sign up now, go to shamelesssex.com. You won't regret it. See you on the beach.
Switching gears, so we're going to move on to IUD pain management options because the CDC recently updated its guidelines on IUD placement, particularly regarding pain management. So I'm wondering, you saw that? You told me about it. Can you walk us through kind of the key changes and why they're such a big deal?
Okay, let's talk about IUD management for a second anyway. People like me and other OBGYNs that I speak to on a regular basis look at something like this and just go, we can't believe that there are any practitioners out there that are not concerned with patients' pain when you're doing what amounts to a painful procedure. Now, one of the reasons I think that it took so long to actually come out with actual guidance is because every practitioner who puts in IUDs has different experiences with how the patient experiences it. And if you happen to put IUDs in a lot of people who have had multiple deliveries or have a high tolerance for pain, I mean, I've actually definitely put IUDs in people where maybe two, where they said, "Oh, you done?" I mean, actually completely, I mean, I'm overboard with like, I want to make sure you're okay. I'm telling you what I'm doing, all these things. And sometimes people just go, okay, just do it. It's fine. I'm good. I'll take a Tylenol. That's the exception.
Rare.
But if I've seen a few of them in my small practice, maybe there are some other people who see that all the time because most of their patients have had a bunch of kids, or, it's easier to put one in after you've had a vaginal delivery. So I think that's why the guidelines took so long, because not everybody has the experience. Like if you work in a clinic where you put a lot of IUDs in teenagers, you better have something really good for pain management because those cervixes are closed. So the procedure for putting in an IUD, let me just go into that for a minute, because
please,
I think that's why there's so much, thought about what can we do to make this easier for people. So you have the uterus and you have the cervix, and they are not completely separate organs, but for the sake of the anatomy, they actually are, even though they're connected. In order to put an IUD where it belongs, which is at the top part of the uterus, we call it at the fundus, you have to get through the cervix in some way that you can implant this device all the way up where it belongs. And if you want to do it safely, you have to be able to not be forcefully putting anything in through the cervix where it has to get up into the uterine cavity. So the cervix has to be open enough to, one, put a measuring device in there. It's called a sound. I equate it with my patients to, okay, you know how when you check your oil, you put something in there and then when it comes out, you can tell where the end of it was so you can know what the measurement was? It's similar to that. So we have to be able to safely put a sound or a ruler inside the uterus so we know how long or how deep the cavity is, because it has to be a certain measurement for certain IUDs to fit safely. Then we take the sound out, and the sound is pretty much the same width of the IUD tube, the insertion tube. And then we have to be able to put it in, release it, because it kind of goes in like a closed up umbrella, like it's closed. We put it in. There are many different devices for IUDs, like some of them slide off, some of them click off with a little knob. But you have to be up at the top and you have to release the arms. And the arms are like a T and they go out to the sides. So if you have access and the cervix is open enough and you can slide the ruler in and then slide the IUD inserter in, the whole thing is like 15 seconds if all the access is there. But the hard part for many patients is for us to get into where the cervix is closed. Because if you haven't had babies, especially if you're younger, teenagers, that cervix, we talk about a lot of food analogies when we're talking about body parts. Like, if you have a fibroid, it might be the size of a plum. But your cervix, you think it looks like a donut, but it actually is a donut with sometimes the hole is not open. The hole is like what do you call it? A dimple, right? A dimple doesn't look like you can get through to the other side. It's just like a little divot. And this is the whole reason that I have this luxury, I don't put any IUDs in anybody the first time they come to my office. Like they can't come in and go, "Hi, I'd like an IUD," and I just lay down and, put it in. I need to assess that cervix. So I have them, get into the position
is
that
it
it would
a
be
hole
for
or is it a dimple?
Exactly. Does it? I always tell them, I don't think your cervix is as friendly and open as I'd like it to be. So, because there are ways to get it open, and all of those ways pretty much are painful. So, if you can make it open with a dilator, which is like a kind of tapered stick where you can kind of push it through, painful. You can, and now this is part of the new CDC guidelines. I don't think the CDC ever said use misoprostol on everybody getting an IUD, because that was never really the case. You could do it on a case-by-case basis. But part of the new guidelines is they do not recommend misoprostol for people getting IUDs. And I personally don't really agree with that, because I do have a lot of success in people who otherwise the cervix was tightly closed. So I think you have to go with what you find in your office. And I find that if I assess somebody's cervix and I go, this is probably going to be difficult, I take that opportunity to tell them how I can make it less difficult, because there are people who are very bent on getting an IUD, and however you need to open that cervix to get it in, they want you to do it. But I also don't want them to be in pain. So the new guidelines are pretty much two things. One is they don't recommend that everybody gets Cytotec or misoprostol the night before, because they find in studies, which you can't argue with studies, but they find that it doesn't make much of difference in the difficulty of insertion. So they're not making that recommendation. And the other thing is not that everybody should get lidocaine, but that it should be available. And for me, this is kind of a no-brainer. When I'm going to do an IUD, you should see the setup in my office. It's like everything's in there that I could possibly need. Every size dilator, lidocaine with a long spinal needle. We don't get anything out and just open everything and just say, we're going to use it all, but it's all available. So the process is, let's say we try to enter that cervix with, I use a couple of different things. Sometimes I'll use a pap smear brush to test it out. Sometimes I'll use a small dilator. I have everything really available to me. Once you are able to get into the cervix, if that's tolerable as far as what you've done to prepare with pain. So the CDC also says it doesn't seem like oral pain medication makes much of a difference. I kind of beg to differ, because I will offer patients whatever they want for oral pain management, as long as, one, they know that if they're going to take something that they're unfamiliar with, they have to have somebody drive them home. And two, if it seems to be kind of overkill, they may end up with the side effects of a narcotic for later on after the procedure. So I use the first time that I see somebody when they're thinking about an IUD to discuss all of this, like what's available to them. Can they have oral pain medication? I ask them, what do you take when you go to the dentist and have a dental procedure done? Because that is usually how people go, oh, yes, I've taken a Vicodin. I've taken a Percocet. Oh, no, that makes me sick. I just take strong ibuprofen. It's their choice, but I really want them to have everything that's available to them. So
wait, back to lidocaine. So lidocaine would numb the area, right?
Lidocaine would numb the area in the same way that when you go to the dentist, it hurts to have the lidocaine injected, but right after it's injected, the area goes numb. So what I usually do is bring the lidocaine with the needle into the room and leave it on the side, telling the patient that we're going to get started. If you want me to inject with lidocaine right away, fine, I will. We'll draw it up and inject. But I usually, and I haven't had anybody, disagree with this, but it depends on, how they feel about the whole procedure. But we get started, and if it seems like the discomfort is inching up, I will stop and go, okay, I can inject now if you feel like that's what it's going to be to make the procedure better or easier for you. So it's kind of all out there. And if you inject, there are areas at the cervix. We look at the cervix like a clock. We inject at 2:00 and 10:00, or certain areas of the cervix to numb it. It does work to make it less painful. But again, the injection hurts too. So, and it takes a little while to take effect. So, like I said before, if I'm able to get in with my dilator and my ruler, then there's really only 15 seconds left. So if that's something that they feel like, I'd rather just feel a 15-second cramp if it's not so bad, because some people say it's not so bad.
God, mine, when I remember it was terrible.
Did anybody give you anything?
Well, I think that I took like some strong ibuprofen or something, but there was no lidocaine offered or anything. I don't honestly, if lidocaine was offered, I don't know how I feel about like a big needle being in my vagina. Like that is scary to me. Like hearing that makes me, ew.
I think what has been shown in studies and what I have found in my office is the thing that makes the whole procedure less terrible is the counseling ahead of time.
Sure,
letting somebody know that they've got so many things available that I am going to stop what I'm doing if they say, nope, not doing it, or they say this is becoming too painful. We can always stop and change course and do something else. I've even had people that are very determined to have an IUD, and I go, I really can't get anything in there. And it's even with lidocaine, it's too uncomfortable for you. We have overnight dilators that I use, something called a laminaria, where I've done probably about 3 or 4 like this. It's a 2-day procedure. I put a laminaria in, which is very thin. It looks like a toothpick. But as fluid gets into it from the cervix over the next 18, 24 hours, it grows and it pushes the cervix open. And they come back the next day. I tell them, go home. I send them home with a good pain medication. We put some betadine in there to make sure they don't get an infection. But they come back the next day and I slide that laminaria out. It's 10 times the size that it was. Wow. The cervix is open and then I can put an IUD right in. And I've done that several times with really good and determined candidates.
Does the laminaria hurt? Like having it in there?
You could put it in with the same parameters as putting in an IUD. You can do lidocaine. You can, I didn't mention this, but I use topical, like gel lidocaine on everybody. And I don't really do it so much for the insertion. I do it because we have to put an instrument on the cervix to hold it in place, to straighten it out so that the canal is straight, because most uterine cervical combinations are not a straight line. There's a curve to your uterus, up or back, and you need to straighten out that curve to make sure you're putting it straight in the cavity. So I use a lot of topical lidocaine, which again, there are studies that say, no, it doesn't make a difference. I do see it makes a difference. And when I think also when I tell somebody I'm using a gel now, like the dentist use on your gums before they do something painful, I think they at least appreciate that I'm trying to use all the different things.
Mm-hmm. Yeah. So, I mean, ultimately it's about, like you said, education and making sure that people know about how to advocate for themselves, right? Because it's very
100%,
possible that their doctor is not going to lay out all these options for them. So I guess to recap, could you kind of make like a short list right now of like when someone who's listening, if they ever do want an IUD, what are the things that they can ask their doctor about or ask for during the procedure?
I think they could ask even for before the procedure to ask, what do you think looking at my cervix? Do you think this is going to be a tough procedure? Because I can tell just by looking, like yesterday I examined somebody and I was like, she had a baby maybe 6 months ago. I was like, oh, I'm not going to need to dilate. She's not going to need any, not that she wouldn't need pain medication. I still would give her pain medication, but there's no way I would need to open that cervix to put it in because it's already a little bit open. So I think people should ask for the exam ahead of time where they could say, I want you to assess my cervix. I'm really interested in an IUD. But if you think it's going to be like a 2-day procedure or it's going to be very uncomfortable or I'm going to need all the things, maybe I'll get an Explanade, or something like that. So I don't have to go through that. That's definitely a conversation to have prior. And then I don't think it's any problem at all to say, what do you offer for pain management for IUD insertion? And could you go over the procedure with me, like from beginning to end, so I know what to expect? And will you walk me through it as you're doing it? I think those are really important things because I think people are very unaware because nobody has said to them, the things that people look at from an educational point of view. I can't tell you how many people come in and go, my friend got her IUD and she told me this. If she told me it was the best thing, then they feel that way. If she told me it was the most painful experience of my life, then that's what they're ready for. And I think I definitely know that people have walked out of my office feeling like that was unexpectedly different. And I'm not saying I can do pain-free IUDs. I would love to do that. But I think the education, the check ahead of time, the offering all the different things. I mean, one little thing that we started doing, which someone suggested to me, we have one of those little beanbag hot packs that when we go in to put an IUD and I tell my front office, It's in the microwave, just turn it on. And then when we're done, we wrap it up in like, pillowcases and whatever. And we offer them, would you like a hot pack on your abdomen? It's a little thing. And it has made such a big difference that people then lie there. Because we do have people lie there for about 10 minutes or so afterwards, because we don't want them to be dizzy or nauseous when they get up, which is a common post-insertion, thing. So little things like that, a hot pack on your belly, how that feels with menstrual cramps, right? So
totally. In fact, I got my period today. So,
good for you.
And usually on day one, it's the worst of cramps. But yeah, I think we have a question here just around, social media and the pain associated with IUD insertion and these like common misconceptions that patients have, right? Whether they think it's going to be fine because someone told them to, or because someone told them it would be, or because, they told them it was going to be the worst pain of their lives and they expect that, right? Like, do you feel like these guidelines and this guidance of recommending this pain management kind of addresses any of these misconceptions, or do you feel like it's a separate thing?
I do think it can address them. And I think practitioners would be well spent to say, hey, have you read about the new guidelines? I'm so happy that people are now learning that there's so many pain options available. And I have those here. I don't see why somebody can't offer all those things. It's not that big a deal to have lidocaine. It might extend your procedure by a couple of minutes because it takes time to set in. But I do think that when something like this comes out, what have you seen as comments under this kind of article? It's about time. Great that they're addressing this. But people who work in the field, like me, who are already doing these things, I don't think it's going to change my practice one bit. I'm happy that people know that there are things available, but I think every person who's thinking about an IUD needs to find some place that they get the explanation that they want. Because if you go in somewhere and they say, okay, I can put it in right now, I think you should walk away. Because it's nice to be able to get it right away, but no preparation, no pain medication, no discussion. And I know there are places that do it like that.
I mean, what the guidelines are signaling is that, we should be paying attention to people's pain, and especially women's pain and people with vulvas. I think like that, the whole idea is like, yeah, maybe great doctors have been doing this for a long time, but why isn't every doctor doing this? And the fact that it's kind of written down by the CDC as guidance, it's kind of like now people should really be paying attention to this if they weren't before.
People should expect it. Right?
Yes.
You should be able to expect going to someone's office that if that's not the norm, that they have things to offer you, maybe that's not where you should go.
Totally.
And also it has a lot to do with training. I got a lot of my training like in a family planning clinic when I was a resident. And then I learned from other people who were doing family planning and contraception. And I think we as doctors very much, they say, learn one, do one, teach one, so that so much of it depends in all of medicine on who are your teachers, who are the people that are showing you how to do it. I mean, if I have students or in my office, this is what I'm showing them. So this is what they should take away as this is the norm,
Right. Mom.
Yes.
You're so good at what you do. It's great to learn from you. And yeah, I think this is like, I don't know, the 15th time that you've been on this podcast, something like that. Who's counting? We gotta go back and count. But before we let you go, we have one more segment here called Booty Call, where we have an anonymous listener write in or leave us a voicemail. And this is a written question that we have. And so I'm going to read it to you and then we can talk about it and you can kind of give your advice. So it says, my question is about navigating the world of birth control. I've tried several methods, oral pills, the patch, IUDs, and non-hormonal options, but I've noticed that whenever I say something isn't working, my doctor or even the sexual health clinic seems to push IUDs, even though they cause me discomfort and weren't covered by my healthcare. Do you think doctors or pharmacists tend to sway patients towards certain birth control options? And what questions can we ask to make sure we're getting the best advice for our individual needs? Last part of it. Also, I find it frustrating that in Canada, government healthcare fully covers Viagra, but only partially covers select birth controls. Do you have any advice on how to navigate these challenges?
Wow. If I could solve the healthcare crisis on what
And
covers
in Canada,
what,
it's better than in the US.
Yeah. I think the first part of it is I don't know of healthcare practitioners who push one method over another. That is not how we are taught to do contraception counseling. When I do contraception counseling, I look at what are the things that are most important to the patient. Because one, if it's most important that you don't have to think about your birth control every day, then I'm not going to talk to you about you should take a pill, because you've already told me either I can't or don't want to take something every day that I have to think about that depends on me thinking about it for it to work. So I think you have to have a list in your head of what do I want to get out of my birth control. You would think that the thing at the top would be, I don't want to be pregnant, but that's not always the case, because except for non-hormonal birth control, which is only for contraception or emergency contraception, all hormonal birth control can be used for things like cycle control, endometriosis, pain control, a lot of other things, PMS, PMDD. So I think you have to be aware, the patient and the healthcare practitioner. The practitioner is there just to guide them so that we can say, I will always say, are you the type of person who wants to take something every day, have all the control, and then if you don't like it, just be able to stop and it's out of your system? And when someone says, yeah, that's what I want, and then you have to go down the rest of it, like, how would you feel about, your period being this way? Like, if you take a pill, your period will always be, it's supposed to always be at the time that it's supposed to come. It's supposed to be shorter and lighter. Your cramps should be more controlled. So if those are all things on your list, that's how we kind of narrow down, how do we know what to suggest to the patient? If they tell me, I like the idea of a birth control pill, but I can never remember to take it every day, then you should go to the next step, which is maybe you want a patch or maybe you want a NuvaRing. But if somebody tells you, oh, I never use tampons for my periods, I don't touch down there. So you're not going to say, NuvaRing, that's great for you. Go put it in your vagina. You have to listen to the patient at giving you a list of most important to me is this. And then what can you tolerate? I can tolerate irregular bleeding as long as I don't have to think about my method every day. Well, the Nexplanon or a progesterone IUD, great idea for you, because you won't have to think about it every day, and you might have to tolerate some irregular bleeding and, of course, some side effects, which here's a list of what could happen. So I think that is how to navigate it, that what's important to you, what's tolerable, what's a big no-no. If somebody says, and I hear this all the time, I absolutely don't want to gain any weight on my birth control. The only birth control that has kind of evidence behind it that it might cause weight gain is Depo-Provera. So if somebody says at the top of my list is weight gain, I'm not going to go, well, at the top of my list for you is Depo-Provera. So it's not my job to direct them to what I think they should have. It's my job to listen to them and have them narrow down all the things they want out of a birth control method. And of course, what is safest for them as well, because there are some contraindications to certain kinds of birth control. And yes, it is my job to direct people away from that. You don't take a 40-year-old with hypertension uncontrolled and go, here's a 35 microgram birth control pill. It's just not the thing to do, because you're putting them more at risk, and there are other things that could be safer.
Yeah. It sounds like for this person, if they've tried all of these methods also, there's condoms also, if that is of interest. And there's other healthcare providers out there for you. Like, if you are not really happy with the advice that you've been getting from your healthcare provider, if you're feeling like you're being swayed to kind of choose one option or another, and you know your own body, like, get a second opinion, get a third opinion, try to figure out what might be going on there. And just also want to say that sucks that in Canada, Viagra is fully covered, but only covers like that's bullshit, obviously.
Oh, don't get me started about that, because Viagra is fully covered here, and many hormones and treatments for vaginal dryness are not covered. Every day I'm navigating the system of like, oh, your insurance doesn't cover this vaginal cream, but it'll cover this thing. No, you wanted the it's crazy. Yeah. But one other thing is that you do want to make sure your healthcare provider knows about all the different methods, because I can't tell you how many patients I tell about Phexxi, which is the birth control gel, which is like a barrier gel. It's not a spermicide. And patients have never heard of it in spite of a big marketing campaign that they did, but a lot of physicians have never heard of it either. And I guess if nobody shows up to your office or you not read journals about the latest things that come out, they wouldn't know about it.
Yeah. Yeah. I think, this is a tricky one because I just have been in this position myself. Like on the podcast, I've talked about this of like, I've also tried oral pills. I've tried the patch. I've tried the IUD. I've tried, the shot. I've tried all of it. Phexy. I've tried it all. And so I think in part this idea that a lot of these birth control options do, like you said, right, Mom, like they do have some sort of side effect, right? Like a lot of them do. And so it's kind of like picking between the least evil for your body. Like if your priority is really to prevent birth control or you need one
pregnancy.
Of these, I mean, sorry.
Don't prevent birth control. What are you, a senator?
Oh, that's funny.
What are you, a senator from a particular state?
Okay, yeah. To prevent pregnancy, then you're going to have to, the response, you said this to me and it's an unfortunate reality, like the responsibility is unfortunately on you. And so in terms of the ultimate question here of like advice on how to navigate these challenges, find a healthcare provider that's in your corner. Try to make sure that you kind of have all the information that you need to advocate for yourself at the doctor or whoever is providing you birth control. And don't give up. Like there will be a method for you, whether that be condoms, whether that be a lower dose oral pill, whether that be Phexy or otherwise. And the final thing I'll say here is if this person has sex with men or people with penises, male birth control is coming soon. It is.
I don't know about soon.
Well, that's the hope. I did recently get contacted by someone to come on the podcast talking about male birth control. So
Good.
I'm curious about that.
I'd be curious to watch men take it.
Yeah, that's a whole other thing.
Yep.
But Mom, do you have any last words here?
Well, I'm glad you're married.
Yeah, you and I both.
I'm always enjoying the time coming on the podcast. I hope that I can provide some, interesting information for your listeners. And
people love it. Oh, I love you. I love you too. And people really love you. We get so much positive feedback for
you don't share it with me. Wait.
Yes, I do. Don't you dare. Well, if you love my mom's episode, please write in to sexedwithdb@gmail.com so I can forward it along to her. And love you so much. Thanks for being on.
Okay. Love you. Talk to you later.
Love you.
Bye.
Our creator, host, and executive producer is me, Danielle Bezalel. Our communications lead is Catherine Cohen. Our producer is Sadie Leegee. Our marketing coordinator is Mitch Coburn. Our social media coordinator is M. Kirsty Frazier. Our music theme is by Hook Sounds. Thanks so much to our featured guests, partners, and listeners. Want to partner with us? Email us at sexedwithdb@gmail.com. Do you have a silly sex story to share, need some advice, or have thoughts on the episode you just heard? Give us a booty call for a chance to be featured on the podcast. Check the show notes for the details. For more sex ed content, follow us on IG at sexedwithdb podcast and on TikTok at sexedwithdb. Want to know your sex toy zodiac sign? Go to our link tree on our IG now. See you next time.